Usually we just start off kind of to get a good view of who's around the table and who will join us today. I'll kick it off. I'm John Fitzpatrick. I volunteer with KC Digital Drive. In my private business, I'm a consultant in strategic business development and work with small companies as well in terms of digital health. I am currently working on a project for KC Digital Drive that's specific to digital equity for community health workers. Jim, you want to say something?
I'm Jim Starsov. I'm program manager for the Solutions Lab at KC Digital Drive.
Stan. Unfortunately, we're not hearing from your microphone, Stan. Still not hearing. All right. Dr. Stan Edlovich is a epidemiologist and longtime health collaborator here in the Kansas City area. Dr. Schuster?
I'm Jen Schuster. I'm a peds infectious disease doctor at Children's Mercy.
Thank you. Dr. Goldman?
I'm the same with a different last name.
Okay. Bob?
I'm Bob Waddell. I'm co-founder of MD Matchup. We match up patients with the right providers. We've got a B2B SaaS product that helps them do that. So,
great. Stephen?
My name's Stephen Coen. I'm the CEO and co-founder of SaRA Health, and I won't spoil anything more besides that, the second half.
Okay. William?
Hi, I'm William Crumpler. I'm a digital inclusion program coordinator with KC Digital Drive.
Doug?
I'm Doug O'Hulan with Nokia. I work with 5G, 6G projects, XR, working on a nursing simulation virtual reality project.
Great. Mike?
If you said Mike, I'll go. It's Mike Mitchell with Unite Us. We are a digital infrastructure company trying to build accountable care networks to connect folks to social services in the communities.
Thanks. Liz?
Hey, I'm Liz Cook. I'm the clinical manager for the telemedicine department at Children's Mercy.
Great. Anurag?
Hey, good morning. My name is Anurag Patel. I'm CEO of About Health, and I also help with the health innovation team here.
Ashley? Ashley, you're on mute still.
You put her
in
the chat.
Oh,
yeah.
Okay.
She's a clinical informaticist nurse at North Kansas City Hospital.
There we go. Thank you. Nan?
Good morning. I'm a health information systems adjunct assistant professor at Johnson County Community College. Thank you.
Great. Aaron?
Aaron Deacon, Managing Director for KC Digital Drive.
Mina?
Hey, good morning, everyone. Mina Fahim, CEO of MediView. We are using mixed reality to give clinicians X-ray vision and enable seamless collaboration at the point of care. Very nice to be on with you.
Great. And your colleague dialing in?
Yeah, it's Scott, and I work for Mina.
I work for Scott in reality.
so whatever he says.
Whatever he says, that's right. Okay. Well, that's our team this morning. We'll probably have a few more joining. I know several who were very interested to be here and then may join us as we go along. But I'd like to go ahead and introduce our first presentation this morning. We have, as I mentioned, Drs. Goldman and Schuster from Children's Mercy. They have been very actively involved in a program, a grant-funded program to do COVID testing in the schools. And so there's a great amount of activity there. And involves data that they're using as well. So very relevant to our digital health types of initiatives. And so I welcome Dr. Schuster and Dr. Goldman to go with us, please.
Well, thanks for having us. So this is, informal. Please feel free to interrupt, or if you have any questions or need clarification. So Jen and I are both pediatric infectious disease physicians who have been spending the past 18 months working really with schools locally and regionally to really support the safe return to school during a pandemic. So we want to just real briefly provide kind of an overview of a COVID-19 testing study that we have really developed in collaboration with KCPS. And then we are going to briefly talk about some of the challenges and successes of school-based research during a pandemic. So I don't think this is news to anyone that kids did not fare well during this pandemic. Many were out of school for over a year. There are lots of lost students and children. And so we have kind of been working with schools to help them as they had kids return to in-person learning. And so we kind of entered into a unique collaboration. So we had been working with Kansas City Public Schools during the entire pandemic. Again, Jen and I kind of developed guidance when there was no guidance for schools. We were meeting with schools basically daily during the pandemic as they started to develop their plans and strategies to get kids back into the classroom. And just as kind of putting this into a framework, like last year, schools, some began in August. CDC really didn't come out with their first guidance for schools until September. So there was really no support for schools as they started to develop their guidance for return to in-person learning for those that were going to attempt that. So last probably January or February, KC Public Schools on one of our discussions had asked about testing and the ability to bring COVID-19 testing into their schools. Really at that time, this was an unusual concept. I think only 1 or 2 schools in the Kansas City metro area were doing that last year. And we really didn't have the ability to go in and provide testing in those schools at that time. However, following that conversation, about a week later, we were introduced to an international company called ICF. One of their focuses is really on school-based initiatives. They partner with the CDC a lot to perform huge program evaluations of basically school-based health programs. And so their strengths are providing surveys and really providing multicultural communications. So they were invited by the National Institutes of Health to apply for a funding opportunity to bring COVID-19 testing into schools. They're based out of Atlanta, our partners, but they had no experience actually working in schools during the pandemic. And so that is how we were introduced to them because, again, Jen and I had been working really across the state, working with the Department of Education, DHSS, to provide kind of expertise as related to pediatric infectious diseases. And so what came out of this collaboration, we have titled School Testing, Learning, and Consultation Study, or the School TLC Study. It is, again, it's funded by the National Institutes of Health, and it is part of the RADXUP Return to School Diagnostic Testing Approaches Initiative. And really the why is that the goal is to keep staff, students, and families safe during in-person learning and avoid school closures. And so what is RADXUP? So it is a program that really is to solicit research on COVID-19 diagnostic testing approaches to safely return children and staff to in-person settings in underserved and vulnerable communities. RADx Up itself is focused on really bringing testing out to the communities more globally. And so that is not just focused on schools, but then again, in February, they really announced, or March, they announced this Safe Return to School diagnostic testing initiative. And so this was fast. I mean, especially for academia, this was really fast. So the NIH invited institutions. Again, our connection was that ICF was invited. And so the NIH put out invitations for applications. Really, the announcement came the end of February, beginning of March. The applications were due at the end of March, and the awards were announced in April. May was expected startup for the first milestone, and this currently is a 1 to 2 year funding mechanism. So we were selected as one of 8 sites across the country, which is pretty exciting. Again, our partners are ICF, Kansas City Public Schools, and then Children's Mercy. And so what we did, I'll go over this a little bit, but we started in the summer in 3 neighborhood schools, so James Elementary, Northeast and East, and then have expanded to additional schools as the program has expanded. So, why is COVID-19 even important in schools? Well, one, the CDC recommends it, especially when community rates are high. And really the concept is if you're able to perform, ideally rapid COVID-19 testing and get the results quickly, this will allow us to keep schools open safely, reduce quarantine for those who, potentially were exposed and can test out of quarantine early, reduce absenteeism, as if someone has allergies or a cold, but they need to get tested for COVID. If that test is negative, they can actually return to school sooner. And then, really we want to help students, staff, and families feel safe with in-person learning and understand really what they need. And so the point of this whole funding approach and mechanism is to create a roadmap for the best in-school testing strategies for the country and really to provide some national guidance. So this is really what we proposed and what we're doing. So in phase 1, so again, rapid startup. So through the summer, our goal, and remember, COVID rates during this time were actually quite low, but our goal was to really implement the surveillance and diagnostic testing strategy and to really perform a formative needs assessment to understand, what schools want, what do families want? We often aren't able to ask them and get that information. And then we're currently in phase 2, and that's really where we took the information, learned what families and kids wanted, and now we are performing really a robust COVID-19 testing program in 8 schools. And this then is supported with medical consultation and communication strategies. And then phase 3, hopefully will continue on next year. And this will be where we disseminate this to other schools and even across the state. So briefly, so phase 1, what did it look like? Well, we were in these 3 schools, and the whole idea was to find out what kids and staff wanted. So this is a study, so people have to consent and agree to be in this, but we were comparing 2 different testing strategies. A self-administered nasal swab that is not the brain tickler, it just goes into the tip of the nose. You twirl it around each nostril for 10 seconds. This is a PCR test. And then we were comparing it to a saliva, or what we called for the kids, the spit test. Again, PCR based, where you then provide a saliva sample. And so we tested 135 students and staff over that 3-month period. We also surveyed 261 parents and talked to 17 parents and staff more globally about what they wanted and needed to feel that their kids were safe while in school. And basically what we learned, so every participant performed both of these tests in random order, and then we asked them scripted questions of what they preferred and why, and what they didn't prefer and why. And overwhelmingly, the nasal swab was preferred over the saliva test, which we were actually surprised by. But even anywhere from kindergarten up to staff really reported that globally it was easier and it was quicker than providing a saliva sample. And we also learned that parents reported not wanting their child tested when the parents weren't there initially. We learned this by participating and working with LINK, which is an after-school program in KCPS, and being able to meet with parents, tell them about the study. And once they realized what they were doing and that they could see their kids being tested, they were like, oh yeah, this is no big deal at all. But that was really important. And then parents want enforcement and mitigation strategies in school, and they do want communication from schools about COVID-19. And with that, I'm going to turn it over to Dr. Schuster.
So now this fall, obviously the landscape has changed quite a bit, and the CDC has really prioritized testing in schools as a mitigation strategy. So we are performing COVID-19 testing. We're doing weekly screening in the schools. We're also offering symptomatic testing. So if a child gets sick at school, they can be swabbed at school. The test is run in our lab, and their parent doesn't have to take them to CVS or Walgreens or their pediatrician to get tested. So it can be done on site. And then we're using the nasal swab because that was what was preferred. We're also doing medical consultation. So we're doing monthly school walkthroughs, looking at other mitigation strategies. So things like distancing and adherence to mask wearing. We're putting out COVID-19 quick facts for the schools, and then starting to do some family forums. And then with that, we have tailored communication strategies that we're working with ICF on, looking at multicultural messaging. We have a website that's hosted by the hospital, various social media buys, using neighborhood organizations and their social media as well to push out the message, and then really focusing on testing and masking behavior. Next slide. So Jen briefly already talked about this, but we are offering two different types of testing: surveillance and symptomatic. So the why is nobody in school has COVID-19 like symptoms, so why should we test? And it's because surveillance testing, or that random testing when you feel well, can identify people who are asymptomatic, and it strengthens school mitigation strategies, and is really what's recommended by the CDC when we're at high rates like what we are right now in Kansas City. And then the second scenario is, as Jen had mentioned, was a student in class who has a runny nose, complains of a sore throat. Maybe their parent thought it was allergies this morning or just a cold, but we know that COVID-19 can look like both of those. And so by offering symptomatic testing at school, we can confirm if this is COVID-19 or not. If it's not, then the child can come back when they feel better and doesn't need to isolate for 10 days. And they don't need to rely on finding testing, which can be difficult to find. Pediatric testing can be difficult for parents to take off work and find transportation as well to get to testing. So we've expanded. So as Jen had mentioned, we were in James, Northeast, and East over the spring and summer, and we've now expanded to the 8 schools that you can see on here. And so where are we? We have almost 600 kids enrolled. We've done over 70 symptomatic tests. We've only had 6 positives, which is great. And we've done over 800 tests since we started on August 26th. And you can see, one of the interesting things is really how we reach parents for enrollment. And you can see that this really varies by school. So for example, at James Elementary, we have 20% of students and staff enrolled. Where at Northeast Middle, we only have 5% of students and staff enrolled. So really understanding kind of the unique ways to reach parents in a pandemic when parents aren't coming into schools as well. So, we talked about that testing, learning, and consultation. Through learning, we're promoting behaviors that help prevent the spread of COVID-19 in schools through testing, mask use, and vaccination, and addressing COVID-19 concerns, knowledge gaps, and barriers related to testing, mask use, and vaccination. And the way that we do education, I think, is so different during the pandemic because so many things have moved to be virtual, and then trying to reach parents who aren't in schools, but also may not have good internet access or a device on which they can get onto the internet. So how do we reach parents and how do we reach students while they are physically in school? So really taking advantage of a lot of KCPS's communication strategies that already exist. And then we're doing longitudinal surveys, which are voluntary for KCPS families, talking about, asking questions about the perceived benefits of testing in schools and the likelihood of vaccinating children, which is really important. Many of you may have seen yesterday that the FDA approved the vaccine for 5 to 11-year-olds. So we suspect that this is going to become an increasing area where we get questions. And the goal of these surveys is to really inform our communication strategy. So finding out what parents want and how they best communicate so that we can communicate that way as well. And then we, for consultation, we're providing educational events through CMH to answer questions. Again, most of these are virtual, and evaluating the mitigation strategies in the schools. And as of last week, we had done 16 events, which totaled about 43 hours. And really, it's a moving target as to what we're talking about. It's not always just testing. It's a lot about vaccination, particularly increasing about vaccination as those 5 to 11-year-olds are getting ready to be eligible, as well as other mitigation strategies. And, I recognize we obviously do not come from a digital background. We are 2 pediatricians, but this has really been an interesting learning curve as to how we linked KCPS, our hospital, and ICF as well. Because this is research, we have to consent parents to be in the study. And for us, that traditionally means a paper consent in person with study staff and the parent physically there. Children have to assent, so they have to agree to be in it. And really thinking about how do we do this in a world where, we don't have direct access to parents because they are not coming into school. And, this isn't a study that's taking place in the hospital. So we've been working a lot with e-consent and verbal consent. Data protection has been a big one because we are doing research outside of the hospital. So as we're bringing information from the schools back to the hospital, how do we protect it? How do we give information to the schools and stay and protect everybody's privacy? And then surveys as well, traditionally often we would do paper surveys or have people come in and take surveys. But, again, we're doing things in a virtual world. So getting things out, making surveys easily available on phones, not necessarily things that you have to take on the computer. And so you can see here's our website. We have a variety of different things that are going out on social media. Again, we're really trying to leverage neighborhood organizations that serve our families and using their social media channels and using KCPS's communication channels as well. So things that are already in existence and readily looked at and read by our population. We e-consent through REDCap, which is an online, if you're not familiar with it, it's used by many in academics, but it is an online research or often used for research platform where everything is protected and secure. And so this is pretty cool. We have a QR code or a link that parents can access. They can select English or Spanish. We have other languages and written consents, and they can do all of this on their phone. It takes less than probably a minute and a half to fill out. And this is, in contrast, we think about consenting in the hospital for various studies. I mean, that can often be a 20 to 30-minute process. So this is pretty cool. And then, just other things related to data protection. We're a hospital. We need to be in HIPAA compliance because we are providing medical data with COVID-19 testing. The schools deal with FERPA on their end. We have a 3-way data use agreement between KCPS, Children's Mercy, and ICF. We have to have a protected way to get COVID-19 test results to the school nurse. So after these kids are tested to determine whether positive or negative. So we need a secure system for that. We need to limit who has access to that medical information as well. All COVID-19 testing also has to be reported to the health department with various demographic data. So figuring out how to navigate that. The schools also have to report it to the state through DESE. We do a lot through REDCap, which I mentioned, which many of you may be familiar with, and really just layers and layers of data protection because this is research operating under multiple IRBs. So our IRB, ICF's IRB, which is the Institutional Review Board, to make sure that we're protecting our subjects. And then also having contracts, so our legal folks on both KCPS, Children's Mercy, and ICF, make sure that everybody's in compliance with kind of their unique nuances that we're used to looking at. And that, I think, is all. We're happy to take questions.
That's great. Thank you very much. This is really exciting. I'm amazed at how robust it became over such a short period of time. That's remarkable for this environment. KC Digital Drive has been very involved in the testing environment and getting messaging out as well. And we know firsthand the challenges involved in that. So it's very impressive. I might ask sort of a practical question first before I think more strategically. And that would be, do the individual students get a Children's Mercy medical record as part of this program if they don't have one already? And do their tests then show up in that medical record?
Yeah, that's a great question. So, the 8 sites are all doing this differently and doing testing differently. The NIH, even though this is a research study, the testing has to be done in what we call a CLIA approved lab, meaning not a research lab, but an actual clinic lab, and using a clinically approved or FDA under the EUA test. So the way that we do that, and in addition, KCPS really wanted PCR testing. They did not want antigen testing. And so we do the tests in our clinical lab. So this is the same, if Jen or I test you in school, it is the same exact test that you would get if you came to our emergency department. And so because of that, yes, every patient has a medical record. It does show up in their clinical chart. So if many of our families have been to Children's Mercy, when we're creating their medical record, we often already find they have an existing medical record. So parents can actually access the results if they've already signed up for our patient portal from, a previous medical encounter, and the results are in there too with the clinical results.
That's great. That's great. Questions from the team? Any thoughts, folks? One of the things I saw that you mentioned was the sharing of information back to the schools through OneDrive. So that's a shared doc or shared file, correct? And that they get.
I am. Yep.
Is that the way it works?
It is, but it's only the access is only allowed for the school nurse. So we did not, again, to what Jen alluded to. This is really merging like medical, testing with the school. And so kind of determining where that line is. We did not want to directly be contacting the parents. Really that is the role of the school nurse for the evaluation. And then they follow all of their procedures for contact tracing, quarantining, all those things that are already in place. So we do use a protected OneDrive Excel sheet that only the school nurse has access to. And so then she can see the results. We also send an email every day as the results go back to make sure that she knows, all were negative, please check OneDrive. But we have used it and it's been very successful because then they can also, if they have a symptomatic case, so someone comes to the nurse because they have a runny nose and cough and the nurse would recommend at baseline, you need COVID-19 testing before you could come back to school. The nurse can see if that patient or student is already enrolled. And if they are, we have procedures in place to then we can courier over the test, and get the result back the next day as well. So it's worked out really well. It definitely took some strategizing and some learning along the way, but we have found it to be a really good system.
That's great. I was really impressed too with your ability to kind of leverage the relationships you have in the community, in particular the link connection that you mentioned. I think that's really a tremendously effective way of going about this. It's interesting, you seem not to have gotten too much pushback along the way either, that once the parents, particularly through that link connection, once they had a chance to kind of get the look and feel of this, they really bought in. That's not the common sort of response that we see published in the news.
So yeah, you bring up a great point. So we have a community advisory board that meets monthly. So we have stakeholders from various different organizations and have had involvement. I think, this is so different from what Jen and I have either done kind of in our previous lives in terms of academics or research, is being out in the community. And I think one of the biggest things is that we have been with the schools for the past 18 months. And so I think that there's been a lot of groundwork set in terms of, our faces being out there and kind of our messaging. I think having Children's Mercy's name and connection with KCPS, I think that also helps. And, this is completely optional. And, when we go out to the schools to talk to people, our goal is really to answer questions and give people really good information. So it's, I think having KCPS support it has been huge. And, I think there's been a lot of talk about, who people trust during a pandemic. And I think a lot of people trust for their children, trust pediatricians. So that's kind of the place that we're coming from. But I will say, having the community advisory board give us their unique perspective, which is so different for each school, various various pediatric populations, has been so helpful and has really informed what we've been doing.
That's great. I have a question here from Dr. Edlovich. His mic's not working, so we have it over the chat here. Since this is grant supported, I assume there's no cost to families. Have you estimated what it would cost to school or school district or parents if not grant supported?
Yeah, that's a great question. So it's really interesting, right? When I would say testing initially, especially in schools, in general was being done by private schools and very few and far between, because it's not only costly for the test, but the manpower to actually do the testing is not insignificant. And the school nurses are typically held responsible for this, and they're already doing a million other things because of COVID. Cost, interestingly, has not really been now an issue overall because of the huge initiative from the White House. So for example, the state of Missouri has $186 million for school testing. And you may be asking, well, gosh, guys, you're only in 8 schools. That's not fair to KCPS. But KCPS is using, for the rest of the schools, is using the state funded testing program. So right now, schools really across Missouri, if they want testing and they're using the state program, it's all paid for by the state. And they have contracted with a company that really started with testing in Massachusetts early on in the pandemic. They're doing a little bit different strategy. But cost would be prohibitive for many schools, non-pandemic wise for sure. And not only the cost of the test, but just, I would say, the cost of the manpower. And that's really, the funding is paying for obviously all the testing, and it's absolutely free to families, of course, but we're also paying for the support of our coordinators to be out there testing, communicating with the nurse, making sure the results all get reported and things like that. And so it's the manpower as well.
I think just to piggyback on that, the manpower, I think, is the biggest issue. When the state or the federal funding came through for testing, I mean, it's easy to throw money at testing, but figuring out how to do this is so nuanced. And what we found is that, I mean, it is different in every single school that we go to. And it's not just, it's the same in all the elementary schools, it's different in every single elementary school as to what works, how we do this. And, our school nurses have been asked to do so much. They're now contact tracing on top of, their daily regular school nurse activities. And then so to ask school nurses to do testing on top of that, Missouri just recently adopted a test to stay policy. But, this is really becoming above and beyond what school personnel can handle. They're just not equipped. And, we probably read in the paper too, most schools are having staffing shortages too. So many schools across the state don't even have a nurse. We're lucky. KCPS has a nurse in every school. But I think really, personnel is kind of the thing that no one is talking about, that there really needs to be, some oomph put behind, because otherwise a testing program just isn't going to work.
But the one thing I will say is the information that we're learning, I mean, the hope would be that this would, expand beyond just COVID-19. The diagnostic testing approach in schools is unique pre-COVID-19, but schools provide so much more than just education to our kids. And so, the thought is if we could figure this out and figure out effective and efficient ways to do some of these, tests, that it could potentially expand beyond just COVID.
This is probably an unfair question, but I'd be interested in knowing from each of you, what was kind of your focus before COVID? What really took up your time and focus before this all happened?
Okay, I'll go first. So mine's probably a little bit more closer to COVID than Jen. So my time, so about a third of my time is clinical, meaning that I see children who have infectious diseases, so various and sundry things that are not COVID-19. About a third of my time is devoted to education. So I'm our fellowship program director, so training other people to be pediatric infectious disease doctors. And then I also have a research component. Mine is related to the epidemiology of respiratory viruses and vaccines and high-risk hosts, particularly for respiratory viruses. So I'm a little bit closer than what Jen is going to tell you to COVID. And we haven't given these things up. This is just kind of the icing on the cake to our cake jobs.
Sure.
Yeah, I mean, the only reason we really got into this is that we couldn't believe that kids were facing a year out of school and just thinking of all the consequences related to that. So, I mean, this was truly passion driven and understanding the science. But I run a lab. I study adverse drug reactions in kids. So I'm clinical pharmacology trained as well. And kids are not little adults. And so how medications are dosed and used in kids, and then kind of trying to identify, predict, and prevent bad reactions to medications. But I also am an infectious disease doc, so I see kids in the hospital too with infections, and then study antibiotic resistance as well. So research focused, but never community based in kind of this part of my career. So it's been amazing.
Well,
if you all don't hear it enough, thank you for being part of our community, and thanks for taking care of our kids.
Absolutely.
We love it. Thank you.
You're kind of begged off a community role earlier, but it's clear through the program that your integration with the community has been outstanding. So that's a great lesson for all of us in terms of how do we get broad-based initiatives to work? And it's really through the community, and you've shown us a way to do that, and we're very grateful for that. Do we have other questions from the team?
I have a light question.
Sorry. Sorry, I just one quick note. Someone here indicating as a parent, thanks very much for your service.
Yeah. So what's next? Like, I feel like this is a great opportunity for other types of testing or even like other community-based preventative health measures. Since you guys have like a direct connects now from Children's Mercy or even your guys' individual departments, testing is hard, I think, like, or from my perspective, like just getting the program in place is like a great platform for other things, i.e. vaccines.
Yeah, so I mean, you bring up a great question. We hope this is not all going away, and I mean even more globally, not just our effort, but I think on a national scale. So there are, like I mentioned, there were 8 programs funded all across the US. So Duke, WashU, Hopkins, big players across the United States where we are all doing different approaches to testing, but we're all trying to kind of figure out what works in different communities, different populations and things like that. And so, I mean, the dream would be that we would be able to put kind of, our findings all together and move forward with some strategies to address kids' health in schools that, again, are, potentially more long lasting and are effective. Jen and I, of course, selfishly, I mean, we're ID docs, so we're like, diagnostic testing for infections would be amazing. Let's flu test them in the school, and all these things. But again, it really matters what the community wants to. But the goal would be to build a platform that is even more expansive and long lasting. I don't know, Jen, you have anything else to add on that?
Yeah, I mean, that's our goal. I think kids spend 7 to 8 hours in school, plus the kids who go to preschool care and after school care. I mean, both of us have children. My kid spends more time in school, right, than I see him during the weekdays. And so for families who have both working parents or other needs, I mean, getting to a doctor is sometimes difficult. And so any medical, while we want every child to have a pediatrician, we want every child to have a medical home, the ability to bring some of these things into the school is amazing. We were testing 2 weeks ago, and UMK, I think it was UMKC, was out doing vision and hearing screenings at one of our elementary schools, right? I mean, so really by bringing these services into the schools and taking every available opportunity to identify a kid who has a hearing problem or a vision problem or didn't get their flu vaccine but needs their flu vaccine, but getting to their pediatrician is really hard because the pediatrician is, I have a hard time getting my kid to the pediatrician to get a flu shot, right? Because I'm a working parent. And so, recognizing that any of these things that we can deliver through the school, it would be amazing. And I think the other thing is people trust schools, right? I mean, people inherently trust their teachers and their school nurses. And so these are trusted members of the community, and working to figure out how we can partner with them to increase access to care is I think where we are hoping to go.
And the one other thing that's unique, I think partnering academia and schools has been, selfishly such a win for us. Like, we know all the school nurses, we are out there literally every day because Jen and I are out there 4 days a week too testing, but it has been really an incredible relationship that one takes time, but they have so many things to teach us. And then again, in academics, I think we do have a lot of things that we could bring out into the community. It's just sometimes there's just all these barriers.
Yeah, thank you very much for that. I'm very much interested in what's next. If there's a way for me to ask questions, is there an email that I could use to?
Yeah, I can put both of our emails in the chat. Would that work?
That'd be awesome.
And I sent our slides to John, and I think our emails are on there as well.
Yes, and we'll be posting the slides with the recording after we've completed the session, as well as the chat. We copy the chat into that as well. Anything else? Well, I'm assuming that some of this leads ultimately to vaccinations as things become approved, as we're seeing this week. So I'm sure there's much more still to be done, but we're very grateful for what you have done and what you've been able to share with us today. If you need to jump off for your very busy schedules, that's fine, but you're welcome to stay with us as we learn a little bit about an innovative effort going on in Kansas City and surrounding areas from Stephen Coen. So I'll introduce Stephen.
Yeah, thank you very much, John. Speaking of respiratory illnesses, I hope mine doesn't detract from the presentation. For better or worse, it's not COVID, so it's almost, there's some comfort in knowing that what I have is just kind of normal life coming back. But yeah, bear with me over some sniffles and a raspier voice than usual. And just want to say thank you, Dr. Goldman, Dr. Schuster. That was really cool, and I would love to dive into what the post-test messaging is and the differentiations across each nurse, and if that is contributing to the different enrollment and consent rate. That's more where I got super interested, but we can follow up after and have that chat. But very, very cool. So thank you, John. Am I good to present slides and head off?
Yes, please. You go ahead and share your screen, and I'm happy to hear what you have to say.
Wonderful. All right. So can I get one thumbs up if slides are showing? Perfect. Thank you. So like I said, my name is Stephen Coen. I'm the CEO and co-founder of SaRA Health. For those of you who have tracked our journey over the last 5 years, you may recognize that rehab is no longer in our name or our principles. So we have focused purely on personalized prevention. So precision medicine and preventing musculoskeletal injuries or decreasing their severities for our highest risk populations. So what are the high risk populations that we are addressing? So we have our core foundation is in the RN, LPN, first responder world. So as employees, they are the only occupations that are seeing actually an increase in injury rates versus a decline as you see across every other industry. So these two occupations are by far the most at risk, and there's really not enough being done in terms of preventing these injuries. And with our growing obesity problem, you're especially for these folks who are going to see the injury rates increasing. For example, in Indiana, 50% of all injuries to firefighters are from picking up an overweight human. So 50% are musculoskeletal for picking up someone overweight, and that problem simply isn't going away. The other area that we are beginning to target, thanks to a recent grant, is the 10 million seniors in the US that fall every year and cause 28,000 deaths. So again, a major problem that is only going to continue to grow as we see our senior population exploding over the course of the next 10 to 20 years. Add those issues, which are bad already and growing, and then add our nation's provider shortage. And really, there needs to be an innovative approach to be able to help tackle these problems. And that's where the SaRA platform comes in. So I'll have some more slides to give some more visuals to how it works. First, we baseline a person's movement health. So we can do this through a few different ways. Our main way is through a virtual assessment, which I'll give a quick tour of. We also can take in data from movement analysis companies and technology like Dari Motion, and also providers are able to create their own movement health program for a person. Second is we empower through a series of exercises that are updated on a very specific cadence. And then finally, we connect through email, text to improve adherence, And then also, I will keep it a little bit hidden for now, but a gamified approach to telehealth that I will get into. So how does the baseline work? We ask our patient, we call it people versus patients. We ask people to go through a series of questions that are video guided. So first we start with a more of a personality and goal questionnaire to be able to understand where someone fits in terms of an active lifestyle, how active is their job, what goals do they have, whether that's improving overhead stability or being able to walk up and down stairs. And then we go through a movement assessment that is specific to each of the personas that we identify through those questions. So whether that's going to be something more athletic like you see on the left, which would likely be going to a nurse or first responder, or something that's more senior specific that you would see off to the right and with the sit to stand and tandem balance. From there, we have an algorithm behind those answers that develops what we call our Empower or our resilience program. What that's going to be is a set of exercises where people can go through, they log their progress. Sorry, it's a little quick. They log their progress on a daily basis and rate their pain, their effort, or any other custom metric we add in, can record videos of themselves and make comments in order to be able to continue to track how they're progressing against their goal that they self-identified in the baselining portion. And then finally, we connect. So we have a series of smart communication tools that we have built internally to be able to really push adherence up, whether that's a simple text for someone who's logged on and recorded their exercises for 3 straight days, and we know we need to get to 4 to improve the chance of adherence for the rest of that month cycle. Or if someone hasn't been on for 3 days, a different message to be able to see what's going on and be able to get feedback into why they're not engaging with their program. The last is on the checkerboard. So as I said before, we recently received grant funding through the Digital Sandbox to build out what we're calling Gray Connect. So it's Gray for senior, and Connect is a juxtaposition of kinetics and connection. So how does it work? With this, you have 2 patients and 1 provider. I have that asterisk because it doesn't have to be a provider. I can get into that a little bit later of how our revenue model differs based on what the delivering network decides to choose. What happens is simply 2 patients play a game. So they play a game of checkers to where they earn the next move in checkers by performing a set of their exercises, with all this being moderated by whoever is the provider or the administrator of the game itself. With the 2 biggest health risks to senior citizens today being isolation and falls, this is what we think an innovative way to be able to tackle both of those problems in one fell swoop. So our foundation for growth has been laid. Right now, we have really done well in the corporate wellness market. So Cerner's Workforce Health Solutions, which I think for Dr. Schuster and Dr. Goldman, they provide the on-site, I think, MSK care for children's employees. They have adopted us as their MSK platform and targeting an employee population of 250,000 by the end of 2022. Beyond that, we've been able to develop customer relationships with especially more niche providers that target the first responder community and have delivered over 4,000 exercises and have changed the lives of first responders like Danielle, who is one of our super users and has delivered a video testimonial, I think multiple at this point, on how this has helped her go from not being able to move confidently to now getting back to, as it says on her shirt, squatting, deadlifting, and beyond, as well as being back on the truck. So now we're looking to use our new product to be able to help the growing senior population. So how are we going to do that? One is leveraging our current Cerner clients. And so For example, Cerner delivers the on-site care for the Chicago plumbers or the Chicago Union. And that union actually continues to hold all the healthcare risk after someone retires. And so transitioning them from a more on-the-job resilience into a fall resilience program using the same platform is where we see a lot of opportunity that's very tangential. Also, we have looked at, we talked to multiple Mayo Clinic providers as the Mayo Clinic continues to look for new ways to provide telehealth, and they're interested more likely from the total joint and potentially primary care angle, which they don't do a lot of at the Mayo Clinic on the primary care side, but where they're interested, as you see that second bullet. Also, we're onboarding new medical advisors, specifically not an orthopedic medicine doc, not a surgeon, but an actual orthopedic medicine doctor, as well as an occupational therapist. So that way we can continue to adapt the product to deliver value to the senior world. And we are looking for someone to continue to help us drive the business side and the market penetration for the senior world. As you can see, we have a few things in the hopper, whether that's Cerner and the Mayo Clinic. We're in talks with both Spring Venture Group and SelectQuote, which are two of the largest Medicare Advantage plan brokers in the U.S., and they're interested in Gray Connect, but more from a marketing and value-add service angle. And then finally, in talks with United Healthcare through one of their subsidiaries that provides primary care, as well as Anthem in particular with the California population that they're trying to really focus on fall prevention. And we believe when we are able to attack both of these markets and really deliver the value that we know we can, that really there is no ceiling for SaRA and the good that we can provide in the world and the change that we can drive by hypothesize, helping live better as well. There are other people in this space. We are by no means the first, nor will be the last. However, where we see a lot of our competitors play is closer to that time of debilitating pain. So our competitors like Hinge and Sword Health are typically at the closer to surgery or no surgery decision point. And that makes a ton of sense because it's easier to measure someone who is debating surgery and now will not get it in terms of an ROI to their typically employer plans. And that's where they have chosen to focus. There's also companies like MedBridge, which is used during the rehab process with some similar functionality in terms of exercise assignment. And then finally, I guess the closest to us, especially on the senior side, would be Nimble. However, they are very, very focused purely on balance training instead of a broader movement resilience. And so their applicability, as they've seen it in the market, has been much smaller than they would have initially, I guess, than I would have targeted myself. A couple other key differentiators. So most of our competitors do require some sort of hardware or device, which we see as a big weakness for folks who are looking for just a simple way to improve their movement health and not a full rehab type of solution. And can talk to us a little bit more, but our multiplayer game is the Gray Connect, and the triage capability is what we've developed with Cerner, where basically everyone takes a virtual assessment, and we have a set of red flag questions that allows us to actually triage to their in-person providers. So that way the providers see the most acute cases of pain and the biggest risk versus just basically guessing and seeing whoever is on their calendar. So a more intelligent way of giving care to an entire employer population based on who needs it the most. The market for senior citizens is growing rapidly. Based on our current pipeline, we believe we can reach a $24 million in ARR, so annual recurring revenue, by the end of 2023, and then look for additional basically areas to be able to become the not so elusive anymore unicorn at a $1 billion valuation, which we assume we would hit at $100 million in revenue. Pricing, just real quick on the employer side. So typically employers are paying 50 cents to $1. We think with our enhancements that we have in our pipeline, we can increase that. But for now, that's where we're at. For the Gray Connect, we have both a non-reimbursed model as well as a reimbursed payment model. So after initial discussions with a billing consultant that is very specific to the physical therapy world, a physical therapist can bill for multiple one-on-one appointments that happen simultaneously, as long as they can prove that they saw every movement from both patients. So with our turn-based setup, this allows for that to be proved, sent to the insurance, and then it increases the billable rate per hour by about 30 to 35% based on our initial projections. Our team, so myself, I come from a consulting background as well as helping Medtronic Diabetes launch their self-insured product, and have my master's in business from the business school at UCLA Anderson, which is where I met the lead, Malik. He's our CTO with a master's in science from UCLA as well, and a Box employee who knows how to scale, and our Box experience, who knows how to scale technology. We also have our head of patient provider experience, Paul Urhat, who is currently an acting doctor of physical therapy at the Mayo Clinic in Rochester, and is a published speaker and award-winning leader in the APTA. And then finally, have connected, or one of our advisors is Ben Rayo, who is the co-founder of Mom's House, as well as a couple other long-term care insurance company that is focused more on the tail end of life, but has helped us get a good idea of where we likely need to play in the senior world. Lastly, because this is almost the have-to slide, can you get bought? Where's the exit potential? So you could look at 3 different areas here. So the Teladoc Livongo, specifically Livongo being the first digital health IPO, and then exiting with the Teladoc merger. The SCAC, which is a $500 million special purpose acquisition company that went public a few months ago, and solely for the purpose of acquiring senior health companies. And then CST, or as you may better know them as Life Alert, exited to Best Buy for $120 million a few years ago. And so finally, I wouldn't be a good entrepreneur if I didn't have an ask section. So a couple with Cerner being the on-site MSK health provider for the children's employees, and knowing there might be a couple children's folks on the line, we would love to be able to have children's as a great win for our virtual assessment that I walked through earlier, and simply just need to activate that through Cerner in our relationship with them. If there's anyone from KU Med, we are looking to have discussions, especially with orthos who perform total joints, to see if there could be an application for their patients as a lighter version of physical therapy for the lower risk patients, or potentially closer to the end of the rehab process. And then finally, a more broad one is if either on the employer side or on the senior side, any of this resonated with you and you would like to get involved in some way, shape, or form. I am constantly asking for help and guidance. I love being a sponge, and would absolutely love to hear from others who potentially have scars in this space and knowledge, and not have to learn it all myself, because that is not a great way to scale. So with that, I want to thank Digital Drive for allowing us to talk a little bit about what we've done and where we're going, and we'll open it up for questions.
That's great, Stephen. Thank you very much. Kick it off by just asking, what does a day in the life of a person actually look like? How do they approach and use the app, and then what happens to what they've done?
Absolutely. So where we've seen the most adherence is with, especially on the fire and police, using it pre-shift and pre-workout. So I can almost tell you exactly where, basically, if a police officer or firefighter is on shift or not based on when they log their exercises. So if I see it at about 7:45 a.m., I know that they're doing it pre-shift to get ready and have some additional resilience. And if they're doing it likely later in the day around noon, then it's probably their off day. But that's typically what we see in terms of the day in life on the first responder specifically. I would say for the nurse and healthcare worker, we don't have enough data there yet to have a good idea on it, but I would hazard a guess that we will see something similar in terms of the pre-shift type behavior with that group as well.
If in the case where the provider doesn't exist, what sort of feedback is the person getting, and you know, how do things move along?
Yeah, so it depends on the setup. So we have some customers which are very much a set it and forget it, to where they have a very set prescription of exercises based on the movement health scan and data that we get in. And so for that, typically feedback is only if they can ask for it, and then we funnel that back to that provider company, and they are able to then basically target those folks one-to-one. And so they really like that because they don't really, they care about the adherence, but what they really care about is being able to address issues very, very quickly and show that high value, high touch service. And so, for example, we had a firefighter at Plainfield that was having some trouble with one of the exercises. We instantly put that back to one of our customers, Protein Tactical, and they were able to get that person in for a screening. And there was nothing wrong, but the fire chief found that to be very, very valuable, and is one of the reasons he quoted when they renewed their contract for an additional 3 years. So just being able to see that full circle and help our customers drive additional revenue is really one of the bigger components.
That's great. What about questions from the rest of the team?
Yeah, can you hear me okay?
Yes.
Yep.
Yeah, Stephen, this is Scott with MediView. My question is, how agile is your data cohort relative to conformability to other subsets or other specialties? Is that something that SaRA is prepared to endeavor to create custom fit for other organizations, or are you guys just staying on task, which is fine, I understand.
Yeah, so we have two ways of delivering. One is our out of the box, which we've created from basically from our head of patient, Dr. Paul Urhat. It's basically coding his brain out. It is more or less what the out of the box is. We have created custom, and we will create more custom programs and pathways. So if there's a specific population that you're thinking about, would love to have that conversation. We built it to be able to basically copy and paste new programs in for those that want to have more or focus on a particular niche, or just have a very particular way of driving movement health. So we have both now, and we will continue to have both in the future.
Got it. I'll figure out a way to connect with you after this call.
Absolutely. Let's do it.
Stephen, you may have a typo in your email contact there. Is that right? Is it SRA or SARA?
It's SRA Health.
Okay.
I am a cheap entrepreneur, and someone wanted to charge me 10 grand for SaRAHealth.com. So there's absolutely no way that I was gonna pay that.
Okay.
Maybe later. But yes, it is SaRAHealth.com. Thank you for asking.
Great. Other questions from the team? One of the questions I had is, when Dari Health was first getting going, they presented to us, and they were at the time still using a kind of an on-site motion capture lab. How do you work with them today? What's that sort of interaction like with Dari?
All right, can you hear me?
Yes.
It cut out like as soon as I heard Dari, and then it just cut out on my phone, and I had to reconnect. So, yeah, I guess sorry to make you repeat.
Oh no, we were fortunate to hear from Dari very early in their stages of development, and at the time, they were full blown motion capture lab, so to speak. How are you working with them today?
They have gotten away from the full lab business model, which I think has been helpful for their growth, and now they solely sell the machine. And what they were looking for is a way to deliver exercises after people got scans, as well as a way to deliver their report. So we are on, I think, about 10 to 15 of their machines right now, with a plan to scale that to closer to 70 plus next year. Basically, as soon as someone gets a scan, as soon as someone does a scan, they get a text that's actually from us, and we deliver the report, the exercises associated, as well as one of our new features coming out will just be information only and not an exercise itself. And so for the providers that they're starting to add that are very interested in that. So basically a way to explain the report using our app versus having to rely on a provider who is typically very crunched for time. So basically we're their, I don't want to say the entire patient facing portion of their business, but as far as a patient portal, we are their patient portal.
Okay. Great.
And yeah, that's where the virtual assessment came out of, is we figured how valuable the here's what's wrong with me piece is as a capability on our platform. And we built, if you know Dari, basically the virtual assessment is Dari very light, if you will. And we found that typically the adherence to exercises is much better when people basically opt in to a very specific thing that they're trying to work on. And so if you have a runner who gets a Dari screen and they have an ankle score that's very good but not perfect, they're actually going to want to work on that versus the potential right shoulder control that would pop up. And so as we built our own virtual assessment, part of that is understanding what people really care about and want to work on, because that's how we've been able to drive higher adherence than with just here's what's wrong with you and no context to the person themselves.
You've been able to get some testimonials. Are there any other kinds of outcomes data or anything that you've been able to reach out?
Not any that are publishable. From our current client base that we're in year 2 for some of the fire departments, we have heard that there have been a lower injury rate as well as lower severity. So the third-party administrator that's tracking all that back to our customer, who then tells us, is saying that the program is working and that they're seeing decreased injuries in terms of severity and just number as well. But that's one of the reasons we're so excited about the Cerner relationship, is because we will be able to have all that outcomes data and case studies.
I'm not sure if it's my connection, but I think we lost you, Stephen. Are there any other questions from the team? Okay, Aaron, is there anything that you'd like to say on behalf of Casey Digital Drive? Any thoughts or announcements?
No, nothing in particular. I think this is great. Appreciate everyone's participation,
Great.
especially our presenters.
Great. Well, let's leave it at that for today. And thanks very much for our presenters. We got to see some really engaging kinds of initiatives from both sides, and we welcome that. That's really part of what we do. And seeing that both organizations had set up all kinds of different relationships, that level of collaboration is something that we at Casey Digital Drive certainly promote. And so we're seeing some people using that strategy very effectively in both of these presentations today. So kudos to both organizations, and again, many thanks. So at that, we'll sign off. Thank you all.
Thank you.
Thanks, John.